Have you ever wondered how EMG and nerve conduction studies can revolutionize the way you diagnose and treat patients? Are you curious about how incorporating electrodiagnostic testing can elevate your practice's clinical outcomes and financial health? And what exactly do EMG and nerve conduction studies reveal about patient conditions that other assessments might miss? If these questions pique your interest and curiosity, you are exactly the right place right now. Welcome to Your Practice, Your Money, where clinical success meets financial freedom. I'm your host, Dr. Dimitrios Kostopoulos, and today we have a fantastic episode lined up for you. Joining me today is a very special guest, Dr. Korry Wheeler. Dr. Wheeler is a distinguished physical therapist and electrophysiologic clinical specialist, currently serving as the Assistant Program Director of the Hands-On Diagnostics Residency Program in Clinical Electrophysiology Testing. Together, we'll dive into the basics of electrodiagnostic testing, demystifying EMG and nerve conduction studies, and exploring how these powerful tools can transform your patient care and practice profitability. So sit back, relax, and get ready to elevate your knowledge and your practice. Let's get started. I would like to welcome you to our 13-week program, Transforming Physical Therapy with Diagnostics. This is a 13-week educational series that helps you elevate patient outcomes and expand your services and thrive in a changing physical therapy landscape. So today's topic will deal with electromyography, nerve conduction studies, and discuss some of the general and introductory components of electrodiagnostic testing. It will be a clinical type of presentation. And this is why I invited today to be joined by the Assistant Program Director of the Hands-On Diagnostics Residency Program in Clinical Electrophysiology Testing, and the Faculty and Assistant Program Director also of our programs of the American Academy of Clinical Electrodiagnosis. Starting, Dr. Korry Wheeler will be joining us today. All right,
so everybody,
here is the idea, right? When we see a patient, no matter if you are a physical therapist, a physician, chiropractor, any healthcare provider, you are going to use some tools that you have in your arsenal to identify the root of the patient's problem. So what we most commonly use are special physical examination tests. So for different conditions, there is a variety of physical examination tests that you can use. And each of these tests has to be able, from a pool of people, from a pool of patients, to identify that this patient indeed has the suspected pathology, but also it has to tell you that with a certain degree of certainty. Okay, and this is where we have the concepts of the sensitivity and specificity of a physical examination test. So when we look at sensitivities and specificities of common physical examination tests, such as the Tinel sign or Fallen sign for carpal tunnel median nerve entrapment pathology, you can see that the sensitivities of these tests are very small. For example, median Tinel's has only a 23% sensitivity, or a Fallen sign, only a 51% sensitivity. If you are looking at a cervical radiculopathy and you do a Sperling's test, it has a 30% sensitivity. So what does this really mean in the clinical world? In the clinic, what does it mean? Well, what it means is that when you have 100 patients in a room and you know that all of them have cervical radiculopathy, all of them have a pinched nerve in the neck, a Sperling's test will be positive in 30% of those cases. So that is not really enough of a sensitivity of a test, right? It may be specific, but not sensitive enough. We need to have testing that is both sensitive enough and specific enough, and to maintain a balance between that specificity and sensitivity. If a test is not sensitive enough, you are going to get a lot of false negatives, which means you are going to miss pathologies that otherwise do exist. And that's why in medicine, we are not using only a single tool to help us identify a pathology, but we are using a variety of tools. In this case, nobody says that you shouldn't be using your physical examination test to identify, let's say, a carpal tunnel pathology or a cubital tunnel or a rotator cuff for that matter, but also utilizing other testing such as electromyography testing and musculoskeletal ultrasound testing can enhance significantly both sensitivity and specificity. For example, here, and I don't list the specificities, but EMG testing, it has an 86% sensitivity for carpal tunnel and a 98% specificity for carpal tunnel, which is huge. So, but let's examine usually what is the common paradigm in physical therapy, in chiropractic, and in other fields of medicine. What you usually do is you will do a physical therapy evaluation, an occupational therapy evaluation, a chiropractic evaluation, a medical evaluation, an assessment of that patient using physical examination tests. You will develop a treatment plan, some treatment intervention. You're going to reevaluate that patient. You're going to continue care. And at some point, you're going to end the care. But again, the effectiveness of your treatment depends on your ability to identify correctly the patient's problem, the patient's root of the problem. And this is why many times you need to use diagnostic testing. Okay, in the primary care setting, the physician sees the patient being obese. They get information about their diet habits. They get information about their blood pressure that they tested in the office. But if the patient, based on their body habitus and the description of their food intake, is such that the physician may suspect that there might be some hypercholesterolemia, they're going to send that patient to do blood work, right? Or if the patient has dizzy spells, the patient has dry mouth, the patient has frequent urination, they're going to send this patient for blood work to identify if the patient has diabetes. So same way, a physician, a physical therapist, a chiropractor, an occupational therapist, a podiatrist, they have the electrodiagnostic tool that they can use by either referring their patients, or if they are of the profession that they can perform such, they can perform electrodiagnostic testing here so that they can come up with a more appropriate treatment plan. But is this just an arbitrary thing that I'm saying right now, or there is some evidence on what I'm saying? Well, there is evidence, and here is the evidence. In 2018, in the journal Muscle and Nerve, the researchers look at the usefulness of electrodiagnostic studies in the diagnosis and management of neuromuscular disorders. And what they identified was that 51.5% of these patients had a change in their diagnosis because of the results of electrodiagnostic studies they had. So a couple of years later, we found this study very, very interesting. And a couple of years later, we said, you know what? We will do our own study. We will replicate this study, but we're going to make it even more robust. We put together a multi-center study with 462 patients across the US in physical therapy settings. And we looked various parameters in that study. We looked at the change in patient management, and we found that almost 61% of the patients who had an EMG test, they required a change in patient management because of the results of the diagnostic testing. But also we looked at patient attitudes and patient participation in their care. 90% of the patients, they were better able to understand their condition, and more than 92%, they felt reassured about their condition, and 89%, they were better able to manage their condition. 92% perceived high value or very high value from the testing that was administered. This is very important, especially when you are looking at patient satisfaction and outcomes. But who are the patients that you may refer for an electrodiagnostic study, or you may perform an electrodiagnostic study to? And here I am using a form, a screening tool that we use in our offices. And not all of these, of course, qualify for electrodiagnostic studies. You see, there is a different color combination here. Here, where you see tendonitis, arthritis, and all that, those are cases where MSK ultrasound would be indicated. But when you have patients with radiating back or neck pain, with numbness, tingling, burning sensation in their legs, their feet, their arms, their hands, if they have weakness in the upper or lower extremities, or loss of sensation, or they have been already diagnosed with neuropathy or diabetes, or they have high consumption of alcohol, or they have hyper or hypothyroidism, or other muscle disease and muscle cramping, these patients would be candidates for electrodiagnostic studies. Now, I'm going to tell you something that you might find it kind of strange, but patients who may have blurred vision, dizziness or vertigo, unsteady gait, hearing problems, headaches, those patients might be candidates for a different type of study or bilateral symptomatology, bilateral numbness and tingling. Those patients might be candidates for another type of electrodiagnostic study called SSEP, somatosensory evoked potential study. And I know that it might even be interesting or weird if I tell you that you can use your EMG machine to evaluate patients with hypertension and hypotension who have dysfunctions of their autonomic nervous system, because your EMG equipment can perform a special testing called ANS testing, autonomic nervous system testing, where you can examine the sympathetic and parasympathetic nervous systems. Also, patients with small fiber neuropathy can be very good candidates for this ANS testing that I talked about. But in general, when you send someone to do an EMG, or if you want to learn to perform an EMG, why do you do it? What are you going to identify through that test? Here is what you're going to identify. You want essentially to decipher among three types of nerve conditions. You want to look at the nerve. Does it have a demyelination, where that would mean that some of the myelin will be displaced across the nerve axon, and that can cause slowing on the conduction velocity of that nerve, and Dr. Wheeler will talk more about that in a moment. Is it some kind of conduction block where all of a sudden the signal stops propagating? Or you have a situation where the axon itself is disrupted and there is axonal loss. And of course, aside from these nerve axon myelin related conditions, you can identify if there is a pathology with the muscle fiber itself, as in a case of myopathy, as well as if there is a problem with the neuromuscular connection, the neuromuscular transmission, in cases of neuromuscular junction problems. So, did we do this just for the knowledge? Did we do this just to know that the myelin or the axon has been disrupted? Would that make a difference in the patient's treatment? Well, it will make a difference. Let me just show you and discuss this for a moment. Every nerve in the body, every peripheral nerve in the body, has three normal mechanical functions: tension, sliding, gliding, and compression. The nerve has to be able to be put in some degree of tension and withstand some degree of tension, it has to have the ability to have both longitudinal as well as transverse sliding and gliding, and it has to have the ability to withstand temporary compression. Now, these things, when they are either limited or too much, they can become dysfunctions. Too much tension or too much compression will cause a tension dysfunction or a compression dysfunction. Too little nerve sliding or gliding, it will cause a nerve sliding and gliding dysfunction. And I have a couple of pictures to show you here so that you can get a little bit an orientation. What I'm showing you here under neuro ultrasound is an image of the median nerve at the wrist, and then we have the tendon right here. So this is the tendon, this is the median nerve. Now, what I'm going to show you in the next image, I'm going to show you how this nerve moves with wrist movement. These two are tendons. And this is the median nerve. When I move my wrist, the median nerve will move in a longitudinal axis, in other words, parallel to the tendons, but also it will move in a transverse capacity away from pressure. So if I have right here the two tendons and the nerve, and I apply pressure on this side of the nerve will tend to move away in a transverse capacity away from the side of pressure. So how all this is important when we are looking at electrodiagnostic studies, okay? Now, let me give you a very simple example. When you do, for example, neuromobilizations, right? You can do what is called a tensioner, where you simultaneously put distal and proximal tension and proximal and distal relaxation on the nerve. And that is called a tensioner. Or you can have what is called the slider glider, which is going to be proximal relaxation, distal tension, followed by distal relaxation, proximal tension. But look at this now. Let's suppose that you have a nerve that you have identified through the EMG testing that there is axonal disruption on that nerve. How intelligent or unintelligent would be for the clinician to perform a tensioner test on an already disrupted axon. So I have this axon that is disrupted, and I am performing a tensioner? No. But how are you going to know without performing electrodiagnostic studies that the axon has been affected or has not been affected? Just with clinical examination. And I know some of you are thinking, I'm going to do manual muscle test, because if the axon is disrupted, then there will be weakness, right? Because I'm losing muscle fibers. Axons are bad, I'm losing muscle. Well, guess what? By the time you are going to have in a manual muscle test a 3+/5, you have lost an incredible amount of axons. And by that time, deciding to do management, which might require at that point surgical management, you're not going to have a full recovery of that patient. your chances for recovery will be much less. While EMG testing, Dr. Wheeler is going to show you, can identify pathology very early on, because with your needle, you are looking at individual small areas and motor units within that muscle at the very early on of the pathology. And because I don't want to monopolize this discussion today, I'm going to bring in Dr. Wheeler. Korry, thank you for joining me today.
What I wanted to go over is really quickly, briefly, some of the things Dr. K talked about with understanding the findings that we might see from our nerve testing. If you were to get a report back from somebody, trying to help break down what you might be seeing. So this first table here should be included in basically every report that you see. And what we're looking at there, the highlighted box is the latency. So that's how long it takes to get from where we stimulate the nerve. In this case, we're looking mostly at the wrist. These numbers here are how long it takes to get from where we stimulated to the muscle that we're testing. And these just happen to be at 8 centimeters. But since we're stimulating at 8 centimeters on all these, we would expect those numbers to be pretty close to the same. But you see here that median nerve takes significantly longer than the ulnar nerve does. That slowing there represents demyelination, some of the fibers. So that nerve propagation is taking longer to get from where we stimulate to where we record. This here is what we're looking at when we talk about the onset. The time that it takes, this is where our stimulation is starting, and this is where this response is starting. So that's the onset time there. This next box is looking at the amplitude. So this gives you the normal values, and all of these are normal amplitudes, which means that the size of the wave here is as big as it should be. Now, one thing you can always imagine in this wave is if I were to draw a whole bunch of dots or circles that represented the axons that were being activated, that gives you a sense of how many axons are healthy and working as they should. If this response were to be maybe this big, we would see that there's fewer axons that are working well. So the size of the amplitude gives us an idea of how many axons are available and working. Last portion here on the motor nerves, conduction velocity is what this CV stands for. Here's again our normal values. All of these are normal, but if we look at what they're measuring, these are measuring from the elbow to the wrist. This is from below elbow to the wrist, above elbow to below elbow. So all of these are normal, which means everything from above the elbow down to the wrist is working as it should be. So as to figure this part out, what we're doing is taking how long it takes to go from the starting of this wave when we stimulated the wrist, and this is the wave that we will create if we stimulate from the elbow, and we take the time between these two areas here and divide that by how long that segment of nerve was, and that will give us our conduction velocity. So the conduction velocity is another representation of the health of the myelin, just like that distal latency was. We will see. So this is basically going over the same thing. This is now the sensory nerve portion of it. Sensory nerves look at latency as well. In this case, we see that the median nerve is a little bit slower than it should be there. Same thing here. Ulnar nerves look okay. Amplitude, we're looking at amplitudes for the sensory nerves. All those look good, which means our axons look like they're doing just fine. It's only the myelin that has been showing some damage. EMG. So this is the EMG chart. So this is when we actually stick a needle into the muscle, record the electrical activity of the muscle. In this particular case that I put up, everything was normal. But these stand for insertional activity, fibrillations, positive sharp waves. You don't have to know about that, but If in any of these boxes there were some abnormal findings, that would be an indication that there was some axonal loss. As Dr. K was talking about, that might help determine where your plan of care is going to go. And I should mention that in these three boxes that were just highlighted there, that signifies that the injury is ongoing or more in the subacute stage. There's some active denervation going on. If we find something in these two boxes, that's going to represent there's a chronic issue going on. So if the amplitudes that come up on the EMG are really large, can indicate some chronic findings. And then polyphasics, this can actually mean a few things. If they're really small, that means that we're showing signs that the axon itself is regenerating from the lesion. If we see normal amplitude polyphasics, that's a good sign that what's happening is the axons that are still present and healthy are reinnervating the muscle fibers that the denervated axons have left. And then large amplitude is another indication that there's some chronic issues that have gone on and we're likely done with the reinnervation. So with this EMG, you can get great information as to whether is there something still going on? Is the body look like it's trying to repair these issues and we still have some room for repair, or if all we see are chronic issues and there's no signs of repair, then your prognosis for getting better is going to be not as well. So that can really help with your plan of care as well, determining where at in this process this patient currently is. I've used it numerous times in patients that have had some serious injuries and wondering, is there still room for improvement? I've even had some physicians send patients to me saying, we're thinking about doing like a tendon transfer. Should we do it now? Should we wait to see if they still have some progress to do? So you can get all sorts of information just from this EMG table. Recruitment over here just gives us some more information about the health of the axons. It's the one area that we can potentially see some demyelinating issues if there was something up at the neck, and there's really not much else that can show us that. This patient here, it was an axillary nerve injury. They wanted to know if I'm not mistaken, I believe this was the patient that they were going to do a reverse total shoulder on, but of course they wanted to know whether she really had a healthy deltoid. This is the response of her deltoid on the symptomatic side. This is the response of the deltoid on the asymptomatic side. You can see a huge difference there. And this is where we see those axons. So she had some current denervation going on, and then she didn't show any signs of chronic. So this is I wouldn't say it's a good thing because she's got a definite nerve injury, but the fact that we're not seeing chronic changes means that there's still a lot of room for improvement in this patient. Anything else that you want to add?
At the end of the day, having the ability through diagnostic testing to truly identify the patient's pathology with certainty and be able to provide better care for your patient, it is absolutely amazing. And you may decide just to refer out for the testing, or you may decide for you yourself to be trained on how to perform these tests and do them. Because if you are a PT, if you are a chiropractor, if you are a podiatrist, if you are a medical doctor, all of you can learn to perform these tests, and you can bill them, and insurance will pay for these tests. And somebody is asking me, how long does it basic carpal tunnel nerve conduction test? Well, first of all, let me just tell you this. I don't like to see NCV test only without EMG test, because remember what Dr. Wheeler showed. He did not show only the case where we have to evaluate the myelin of the nerve, which you can evaluate the myelin through the nerve conduction study, but you have to look at the axon. And yes, the amplitude of the waveform can provide indication of axonal pathology. However, by the time you're going to see a depression of the amplitude, you're going to be, well, significantly affected. Well, the needle EMG with precision can show you if there is axonal pathology very, very early on. It can aid in early detection, and that can make the world of a difference for your patients. I also want to mention here that any further questions that you may have, I have put here my information, dimi@handsonpt.org, Dr. Korry Wheelers at korry@ihads.com. You can also call us at 888-447-6014. Go to the websites handsondiagnostics.com, discoverdiagnostics.com, and yourpracticeyourmoney.com. Thank you all for attending today's presentation. Dr. Wheeler, thank you. And we
Thank
will
you.
see you next week with an equally interesting presentation. Have a good evening, everyone. Thanks so much for joining us today. If you are looking for additional resources and insights from today's episode, be sure to visit our website, yourpracticeyourmoney.com. Remember to subscribe to the podcast so you never miss an episode. We'll see you next week with another exciting topic designed to boost your clinical success and financial freedom. Until then, stay informed, stay successful, and we'll talk soon. Take care.